Yeah. 1, 2, 1, 2. 1, 2, 1, 2. Hey, how you guys feeling? Forevermore, forever's a mighty long time, and I really want to spend it with you. I shine when you shine, and there's really no substitute. Forevermore, forever's a mighty long time, and I really want to spend it with you. I shine when you shine, and there's really no, hey, take a picture. I want you to remember when I press my love. Press the button. I hope that you're recording. Every word I'm saying to you, I'm telling you right now from this day on. Already weighed out the pros and cons, telling me you're just the woman I want. I want, I want. I'm making my plans just to be with you and showing me paid to the days I do. And I ain't ashamed love to say I do. I do. Forevermore, forever's a mighty long time, and I really want to spend it with you. Hey, I shine when you shine, and there's really no substitute. Forevermore, forever's a mighty long time, and I really want to spend it with you, darling. I shine when you shine, and there's really no forevermore.
Thank you. Thank you so much.
Thank you. Appreciate you. All right.
Well, it's my great privilege to welcome everyone and to introduce our moderator, the reason that we're all brought here this evening, and give you some insight into the background on this amazing organization called the Chrysalis Initiative. So I get to introduce my friend and my buddy and my sister. The Chrysalis Initiative was born from Jamil Rivers' experiences, offering guidance to women on how to thrive with breast cancer, even as she was receiving chemo herself. At 39 years old, Jamil was diagnosed with metastatic breast cancer de novo, and the determination to fight and survive for her family launched her into really rigorous research to understand and contend with breast cancer. And this extensive research journey she took became a lifelong commitment to exploring and enacting optimal and comprehensive breast cancer care. From there, Jamil went on to participate in numerous community health events, which facilitated design and funding of 2 metastatic clinical trials. And these offered her the opportunity to meet with leadership within the Pennsylvania governor's office and with congressional leaders in Washington, D.C. She became an advocate using her knowledge base and experience to help advance legislative policy, medical research, and really customized support to better meet the need of individuals who have breast cancer, particularly metastatic, Black patients, and other disparate groups. Jamil is currently the board president of Mediviva Research and Support. She is a Young Advocate alum. She's a board member of Living Beyond Breast Cancer and advisory chair of Knowledge is Power, Understanding the Black Breast Cancer Experience series. She is a policy, science, and health equity advocate and metastatic advisory committee member with Susan G. Komen as well. In addition to all this, she is a member and advisor of the Metastatic Breast Cancer Alliance, NBC Alliance. Jamil is a project lead graduate. She's a proposal reviewer for the Breast Cancer Research Foundation and program with the Department of Defense. She testified to the FDA in order to connect women with resources for screening, treatment, and support. Jamil has been featured in People magazine, the Philadelphia Inquirer, the Philadelphia Tribune, national campaigns for anthropology, Novartis, Pfizer, Cancer and Careers, and she has been seen on CBS News, and you might have even seen her on Good Morning America. Jamil incorporates integrative therapies as well, and she's doing well thanks to chemotherapy coupled with improved nutrition. She and her husband have 3 beautiful children, and they reside in Drexel Hill, Pennsylvania. It's my distinct honor and privilege to introduce you the CEO and the founder of the Chrysalis Initiative, Jamil Rivers.
Right. Suki now. That sounds really important. Thank you so much, Dr. Mel. I am so excited for the launch of our breast cancer education series, sponsored by GE Healthcare. And we have a dynamic panel. We are really going to get into it today. So I just want to, of course, introduce Dr. Haley Noman. She is a graduate of Indiana University School of Medicine. Dr. Noman completed her residency in internal business medicine at Barnes Jewish Hospital of Washington University in St. Louis. She subsequently completed a fellowship in hematology oncology at Fox Chase Cancer Center at Temple University, during which time she investigated bone marrow toxicity in BRCA mutation carriers undergoing chemotherapy for breast cancer. Dr. Noman maintains membership in both the American Society of Clinical Oncology and the American Society of Hematology. Board certified in internal medicine, she sees patients with breast cancer at the Perman Center for Advanced Medicine. Also, Dr. Monique Gary is joining us today, and she is a board certified fellowship trained breast surgical oncologist and medical director of the cancer program for Grandview Health Penn Cancer Network in Sellersville, Pennsylvania, where she also serves as director of the breast program in the cancer genetics and risk assessment programs. Dr. Gary completed her medical degree at the Philadelphia College of Osteopathic Medicine and her general surgery training at the UMass, followed by breast surgical oncology fellowship at Georgetown University. Dr. Gary holds faculty appointments at PCOM, Penn Medicine, and Texas Christian University, UNT Health Sciences in Fort Worth, Texas. In addition, Dr. Gary is the daily public expert for Radio 1 stations and the weekly co-host of the National Cancer-Focused Education Advocacy Program, The Doctor is In. She is published in multiple peer-reviewed journals and is an invited speaker at national cancer meetings annually. She is a committee chair and member of the board of directors for the American Society of Breast Surgeons. And we also have Dr. Kamal Jabari. She is a medical oncologist and researcher at Memorial Sloan Kettering. And sees approximately 300 people across Memorial Sloan Kettering Cancer Center in Manhattan. And we also have a dynamic patient advocate who is a fellow board member with me for Mediviva research and support. She was originally diagnosed with stage 2B breast cancer in 2008 and was diagnosed with metastatic breast cancer on her 53rd birthday, and has been a fantastic advocate, one that I look up to. She's a member of the Metastatic Breast Cancer Alliance and the ABC Global Alliance, a consumer reviewer for the Department of Defense Breast Cancer Research Program, and a past medical director of MedUp. And so the first thing that we wanted to talk about this evening with metastatic breast cancer is that it's usually confusing as to what is standard of care and what are the
Is everyone else frozen or is it me?
No, I think Jamil
You
is
have connectivity? All right, then I'll pick up where she left off, and we can address it to the first couple panelists, and we can talk about, how do you explain to patients in ways they can understand what the standard of care is. I guess let's start there, because we give a diagnosis and we say metastatic breast cancer, and then we say, okay, here's what you should do. But how do patients know that there is a standard and what that standard is?
Start off
And
there's not necessarily a standard. A lot of oncologists go by NCCN guidelines. There is a patient-facing section of NCCN, but not everybody knows about it. It's not always the most understandable thing on the planet Earth, and the landscape is changing so rapidly that it's hard, and we're so different. There's so many different subtypes of breast cancer, and then molecular subtypes within the receptor subtypes, that it makes it difficult. Most of us are treated in community oncology centers, and we're treated by general oncologists who may not be going to ASCO and SABCS and may not know the latest and greatest. So, yeah, from a patient standpoint, I think that it's very challenging.
Thank you for sharing that.
I'm one of the medical oncologists, and I think this is a very broad question with not one answer. You know, I see patients in consultation pretty much every day with, you know, who are in the different phases of treatment for their breast cancer. Some women, when the word metastatic is introduced, they've been treated for years for you know, early stage or later stage breast cancer, but they're just hearing the word metastatic. Whereas other women are diagnosed with upfront, what we call de novo metastatic disease, where it's the word that we're using on the first visit. So, you know, when I'm thinking about each individual patient and how am I best, you know, how am I coming up with a treatment plan for an individual, you know, sitting in front of me, I'm thinking of so many factors. What is the medical health of the patient? What other medical problems do they have that might impact the treatment? What is the tumor subtype, the estrogen receptor, progesterone receptor, and HER2 results of this tumor? That has a major impact on what would be the recommended treatment. I'm also thinking about clinically, how is this patient doing? Is this someone that is asymptomatic or minimally symptomatic from their metastatic disease? Or is this someone who has a significant disease burden where they actually are quite symptomatic from their metastatic cancer? And what cancer treatments has the person had before? I mean, these are just a few small, you know, not small, but few things that come to mind, you know, when I'm trying to decide what to do. I do hearken to the NCCN guidelines every day, you know, but I don't necessarily mention that in a first visit with a patient. But I do try to explain what is standard of care and also explain to a patient if I'm suggesting something that may be outside of the standard of care, why that is, and, you know, what are the options for the patient.
I'll add to that and agree with what has already been said. I think, you know, the conversation at the first visit can be so tricky and yet so important because there's just so much information being discussed and bounced back to somebody who's already very overwhelmed with this diagnosis, right? May it be recurrent disease that is, you know, somebody who's dealt with breast cancer diagnosis and now is dealing with a different phase of breast cancer and therapy for breast cancer, or somebody who's just newly diagnosed. Regardless, it's very overwhelming and very stressful, to say the least. So partly that conversation is dependent upon how much, you know, understanding the patient and the family has at that time. How much do they understand? What is it that we can help them to first understand what this is, and that this is going to be okay, and that we're going to work together as a team to be able to get them through this phase. And I think that really is very important in the first part. And then certainly we talk about, you know, what is a standard and what does standard mean and how does that standard come by? I think we talk about why certain drugs that got approved are now considered a new standard if they were a new standard. And that this comes in from level 1 evidence from trials that helped us understand that when patients got a certain therapy, they did this way versus somebody who got a previous standard. This is how they did, and this is what this adds, and how a risk-benefit ratio from this data has led this to be a standard of care that might be relevant for that particular patient, and whether they do fit the bill for that. Do their prior issues, as was being discussed, what their age is, what other comorbidities are present, did they have prior therapies, how did they do on those therapies, what the toxicities and side effect from a new therapy would look like. And all of that goes into that decision-making process, ultimately then turning out to be an exchange of questions, thoughts, understanding before a shared patient-physician decision-making process occurs. And certainly if there are appropriate clinical trials, and I'll certainly say that because we do a whole lot of that at Memorial Sloan Kettering here in New York. we do discuss that this would be what we would think would be a current standard of care, and this is an appropriate clinical trial, and both would be an appropriate option. This is what you would expect from a clinical trial enrollment. This is what you would expect with respect to how you would feel, how the cancer would do, and what the side effects would look like, and ultimately make sure that all that understanding is in place. But yeah, it's really in the first visit a little overwhelming, and that's when we really have to establish that trust, that connection, which I think is very, very important for somebody when they meet their doctor and are having this discussion.
Dr. Javere, I love that you brought that up, that it really depends on their level of understanding already. And so, as the surgeon, sometimes I am the first person to tell a person that they have breast cancer. And then we go down this pathway of discovery that ultimately may lead to metastatic disease, where we thought it perhaps was earlier stage disease. And it can be a little bit confusing. But I think from my standpoint, I really try to arm the patient with the basics surrounding breast cancer, meaning, what type of cancer do they have? What are their tumor markers and some of the, the hormone receptors, and kind of understanding how cancer care goes, who's part of your team, what might you hear at these subsequent appointments? Because if they're hearing it all for the first time, you're right, it's completely overwhelming. But if they understand some things and say, okay, well, Dr. Gary said, I get the hormone receptor part, or I understand this part, or she showed me the NCCN guidelines, then when they get to you, they can have a more robust conversation, because you're not starting from the very beginning. What is cancer? Because it's not something that people really understand or know about until a lot of times they're diagnosed, or until their loved one is diagnosed.
I absolutely agree. And when we have this knowledge that, say, a patient had seen a surgeon, and we're talking about early stage disease, or a patient had come for a second opinion and they've had a discussion with another doctor at another institution, I sometimes start with a open-ended question. I will start with, what is your understanding of what kind of breast cancer you have, or what needs to be done? And I think that open-ended question gives me a sense of, where am I starting with this patient? What is it that I can help clarify and add to what they already know? So it totally depends on whether I am their first ever encounter, and how would that be approached, versus if they've met somebody else and maybe they have some understanding, maybe they don't, but I don't know that until I ask them that. So I think in that scenario, starting with an open-ended question, because if they've had a discussion with their surgeon, I think it just helps hear things twice, helps us understand what they understand well, what can be clarified better.
Thank you so much, Dr. Mo, for filling in when I lost connection. I think we want to touch on also on what are those NCCN guidelines. We find that many of the women of color, typically when they're connected to the Chrysalis initiative, that there have been some steps that are missed in that initial diagnostic workup, which any information that is omitted, or if that diagnostic workup is incomplete, then that can typically lead to them being administer the wrong treatment plan. And so we really want to empower patients to understand, if they are newly diagnosed metastatic, whether it's de novo, metastatic from the start, or whether or not if it's a recurrence, how do they know if there is anything lacking? Because this is a dynamic panel. You guys are tremendous, compassionate, highly skilled professionals, but at times there are many patients only being treated by folks that could be impacted by bias in their care. And so how can, our patient community, which is primarily of color, make sure that they understand what is that baseline as far as the testing that should be included in that initial diagnosis? That question, Dr. Noman, can you touch on that?
Yeah, this is also a really challenging question to answer, because again, there's not one right answer here. But so NCCN guidelines are a published set of national guidelines that are frequently updated based on the available evidence and clinical trials as they are being reported out. So national guidelines are trying to set a standard of care, for people, whether they're being treated in Pennsylvania, Texas, or Washington State, that people across the country and really across the world are getting standard of care. And these guidelines are actually pretty dense. There's over 100 slides in the, in the breast cancer NCCN guidelines, but there are guidelines for each tumor type, each cancer type. Technically, anyone can set up an account and view the NCCN guidelines, but I think that this is really, I look at my job sort of as a medical oncologist, breast cancer specialist, to be able to really try to use the NCCN guidelines as a baseline or backbone of how I design a treatment plan for each patient and help patients understand what is the standard of care. And I often say that this is the standard of care. This is the same treatment that you should be offered here or anywhere else, in the country. And if I ever step outside of the standard of care, which I do quite often for various reasons, then I let the patient know, hey, this is why I chose to do this in your case, because XYZ. So I think that, a person Googling the NCCN guidelines, this can really be a tough thing, a big, taking a big bite to chew, so to say. It's very dense, and I think it can be really challenging for someone to try to read these guidelines themselves. But I think using organizations like this, other organizations which, connect women who are, being treated for metastatic breast cancer to compare experiences, to encourage, I always encourage second opinions for my patients. If anyone, wants to look outside of our institution to see if there's any other thoughts that other doctors have. But ultimately, I really try to have an open line of communication with my patients, let them know what is standard of care, and also, emphasize or educate if I'm not using standard of care for some reason.
Dr. Javeri, can you talk about some of the indicators, such as subtypes, such as genetic testing or any biomarker or mutations that kind of lead into the decision as to what treatment options are available? I know that there's a wide range of options that can be selected, but for patients going in, how can they understand subtype, biomarkers, mutations, and also stage? How does, and in particular, metastatic, and how treatment naive they are, whether or not if it's a recurrence or whether or not if there are any other drivers or if it's de novo. What are the most important factors that are helping you recommend the treatment plan for that particular patient?
I think, whether it's early stage or whether it's late stage, right? We're thinking about disease characteristics as the first thing when we start, right? So this is breast cancer. What are the disease characteristics here? Is this something that has estrogen and progesterone receptor expression? Does it lack estrogen but has HER2 positivity? Does it lack all three, which we call as triple negative breast cancer? And depending on that, we then think about, okay, if it is HER2 positive disease, how big is the tumor if we're referring to early stage disease? So we're looking at tumor and disease characteristics as one category. Then we're looking at patient characteristics as the second category, right? Is this patient a menopausal woman? Is this a premenopausal woman? Was this cancer screen detected on a mammogram? Patient always had mammograms done, and was this detected that way? Did the patient never have mammograms? Was this something that grew between mammograms? Because sometimes we have these aggressive tumors that, despite having a normal mammogram the previous year, we have a different, finding that patients come up with. They felt something that led to the diagnosis. What other comorbidities they have? Do they have any reasons that we need to keep in mind when we're thinking about certain therapies? And the last that we think about are treatment characteristics itself. What is the risk-benefit ratio? What is the toxicity profile? And how does that toxicity impact the decision we make when we're looking at an individual patient for us? So there's a guideline that helps guide the decision that a node-positive premenopausal woman who develops a newly diagnosed early stage breast cancer would be appropriate to get chemotherapy. But say if this patient has a comorbidity that might come in the way of a given chemotherapy, right? How does that characteristic then help this individual patient? So I think as Dr. Nolman was pointing out, there are guidelines that help guide a decision, but then there are individualized decisions that one has to make based on a patient in front of you. And how does that guideline apply to that patient? And what is it that we think about? So we think about these three broad categories, as we said: patient characteristics, disease characteristics, and then treatment characteristics that we want to keep in mind. Same thing when we think about late stage disease, and we were talking about biomarker testing. I think we now have, say, PARP inhibitors that are approved for patients that carry the germline BRCA mutations. And, we know that that is seen more in Afro-American women, where we've seen triple negative breast cancer more. It's more, predominantly seen there. Not that that's all we see, but we see a little bit more of that. But we now have PARP inhibitors that are approved both for early stage and late stage. So we want to highlight that. We want to look for that. We want to look for, has this patient had that? Is this a young woman with a family history? Is this a patient who would have fit the criteria, say, for early stage PARP inhibitor for a year, the olaparib that got approved? And has this woman been tested for that? So we think about mutation testing when we're thinking about how do we apply that result and have an actionable item, right? Because it's nice to order a test and get a result. But if you can't act on it and you cannot offer anything for that particular scenario, then I'm not sure that you have to do it. So I don't think everybody has to do a next generation sequencing assay for every time point or for every sample that might be there. But now we have so many therapies that are approved that we try and do that more and more because it's applicable for a treatment decision. So for ER positive breast cancer, we at least have two therapies that we can think about. One is this germline testing that we can do for BRCA mutations, because for very high risk patients in early stage, which was defined as 4 or more positive nodes, or somebody who had neoadjuvant therapy and had significant residual disease burden after chemotherapy, yet at surgery. And if they were a germline carrier, we want to make sure we were tested for that germline mutation to be able to offer olaparib, because that has a survival outcome implication. Similarly, if somebody has metastatic disease with ER positive disease, we have PARP inhibitors for them, but we also have PI3K inhibitors, PIK3CA inhibitors, alpelisib is approved, and 40% of our patients have tumors that harbor PIK3CA mutation. So we think about thinking about a test because we have something to offer, and that's when we think about it. There are standard of care drugs that we might still consider, even say if somebody is newly diagnosed with ER positive metastatic disease, and we know they have a PIK3CA mutation, but we know we also have CDK4/6 inhibitors, which without, whether you have the PIK3CA mutation or not, would work and have shown to have a survival impact, right? We've seen over a 5-year overall survival benefit. We want to still consider that option, but this PIK3CA mutation information is helpful should the CDK4/6 inhibitor stop working. And then we can think about offering the next targeted therapy. So that's how we think about applying this fancy testing that is now available, especially if we can offer a new treatment for our patient. And we have to keep all these 3 basic characteristics in mind to make sure that the benefit and the risk work for this individual patient.
Janelle, can I jump in and say something? It's a lot from a patient perspective, I think, to take in, because it sounds like there's a standard, but then there's if you this, and it can be confusing. Right. And when you read statistics like, for triple negative disease, Black women are 48% less likely to get the standard of care, guideline-based care, which means you get it, but I don't, or I get it, but the next lady doesn't. There are reasons why, and those statistics don't exist in a vacuum, right? Because we understand that, yes, there can be bias in the health system. That means a woman wasn't offered the standard of care or that basic guideline-based care. But then we also understand that there may be some comorbidities or things that preclude that patient from getting that standard. There may be some nuances to their tumor that makes something else more advantageous to try. And so I think from the patient perspective, one of the most important questions you can ask is why? Why and what next? So why do I get this? Once you kind of understand this roadmap of like, who's on first for NCCN guidelines, and the next question really is, well, why are we selecting what we're selecting? And then what comes next? Because exactly, what our colleagues have said, they're always thinking about what comes next. What's the tumor telling us? What's the drug going to do? What happens, and where are we lining up something in addition if this drug doesn't have the effect that we hope that it will? And for the patient, those two questions can really help to shine a light on where we're going in their treatment. Otherwise, it just seems like they're picking things out and we'll try this and we'll do this and do that. But when you ask those questions and recognize also that it is not a menu for you to select, well, I'm going to do this, but I won't do this, but I won't do that, and understand that there is a standard. That collaboration together, I think, is really, really powerful, because nobody wants chemo, let's be honest, right? But there is a standard of care that can be, that has been shown to have some survival benefit. And I think patients really do need to understand that, and not just, it's sort of a selection process of, I'll do the surgery or I'll do this, but I don't want to do that. I might do the hormonal therapy, but I'm not going to do the other things. And yes, the patient has autonomy, but that standard is there for a reason.
Yeah, no, I think awareness and understanding is very important. Sorry, Jamil, I didn't mean to speak over you.
No.
Go ahead and say. I just wanted to have a follow-up comment.
Oh, no, go ahead.
Okay. Thank you. No, I was just going to say, I completely agree with you, which is why, we were saying that I think starting with an open-ended question when the patient sees you first, I think is really important, right? Because that sets the stage really of, exactly how are they processing all this information? What is their current understanding? And how can we help increase that awareness about what's happening right now? What is it that we're dealing with? What is it that would be appropriate as a next step therapy for them, right? Because that's where we have to start first. And when, as I said, when I'm meeting a patient who's met a surgeon, I always start with an open-ended question. So tell me, what is your understanding so far? What have you understood so far about your diagnosis and what your cancer is about? Or if I'm meeting them for the first time, I am the person who's actually doing that for them, right? And I want to explain it to them in a very simplistic way as to what this overwhelming diagnosis means. What does a grade mean? What does a stage mean? What does pathologic complete response mean if I'm offering them chemotherapy before surgery? So that's a whole lot. And yes, I think you have to have those open-ended questions. You have to have, that understanding of why something is being discussed and where that comes from. And then ultimately, as I said, it always is a patient-physician's shared decision-making. It cannot be that, oh, this is what you should do. Sometimes patients tell you to do that. Sometimes they would say, what will you do? I'm here to just listen to say and tell me what I should do. I will. And then there'll be patients who obviously want to absolutely be involved. And so I think it depends on exactly how that interaction is, what their level of understanding is. How can you help them get more aware of the situation and then move forward in that decision process?
So it sounds like the biggest takeaway for patients to understand is that there should be validation. Be aware and seek out the most up-to-date guidelines. Ask your oncologist and your team what is driving their decisions and their recommendations, and understanding that you do need complete testing to help validate and support the decision making. So I think, patients, yes, encourage that shared decision making, but as doctors are sharing their treatment recommendations, what is feeding and driving that decision making? So I also wanted to just touch on, I think we touched on the initial genetic and genomic testing of the tumor and doing the biopsies to determine the subtype and determine stage, and how all of those different indicators determine what the treatment recommendation is for patients. Can we also talk about, are there, an ER positive in particular, metastatic breast cancer, are there tests that can, in addition to the biomarkers, give an indicator whether or not if someone is going to respond positively to moving forward with the CDK4/6 inhibitor, or if there's an indication that they might not have that durable response? And also, can you touch on the utilization of molecular imaging in ER positive metastatic breast cancer? Whoever wants to go.
So I can handle some of that. So you asked about genetic and genomic testing of tumors and how this has implications, on treatment recommendations. So, genetic testing, or when I use the words genetic testing or genomic testing, genetic testing is what I refer to there is testing a person's blood or saliva to see if they were born with a mutation that put them at risk for breast cancer. Now, this is different from genomic testing, with genomic testing being testing the tumor to assess what mutations might be driving those cancer cells. Both types of testing are very important, but they're different and they really answer different questions. So genomic testing, there are many different types of tests that can be done. And honestly, over the last couple of years, my own use of genomic testing has changed. When someone has metastatic breast cancer, whether it's a recurrence of a prior tumor or a newly diagnosed metastatic cancer, we always want to obtain a tissue biopsy. This tissue biopsy will give us information such as, number one, confirming that this is in fact breast cancer and telling us the estrogen, progesterone receptor, and HER2 status, which certainly has implications for treatment. So that's, quick information that comes back within a couple of days from a biopsy. If we wanted to pursue genomic testing, which I very often do, genomic testing can tell us what is the mutational burden of these cancer cells, and are there any mutations that are driving these cancer cells to grow and spread. Some mutations do not have any medications that can target them, but several mutations are now what we call actionable, meaning that there are medications that can be used to specifically target a certain mutation. One of these examples, I think Dr. Javeri had referred to, is called a PIK3CA mutation. This is a mutation that is present in about 40% of women with estrogen-driven metastatic breast cancer. That would tell us that a medication known as alpelisib or Piqray might be effective or might be a reasonable choice after progression on a CDK4/6 inhibitor. And we wouldn't know this information without doing the genomic testing. There are multiple other examples of that type of molecular result that might impact someone's treatment. In terms of when this testing happens and how does it happen, these are things that your doctor would order for you. These are tests that I discuss with a patient at initial diagnosis. And when I said that my own utility of these tests has changed in the last couple of years, what I mean by that is several years ago, I would typically wait to do genomic testing until progression. But more recently, in the more recent couple of years, I've been doing genomic testing more upfront with women with metastatic breast cancer, because these genomic results or driver mutations can have sometimes big implications on treatment. So maybe I'll stop there. And there was a second part to the question about targeted type of imaging. And maybe I'll let, if any other panelists want to either add anything to what I've already said or touch on the topic of the imaging.
I could try to chime in. It's a little bit complicated, but
there's a chance. Go ahead.
No worries. I talk in food because people know food, right? And so the way cancer cells, let's see, how do I say it? Tumors are what we call heterogeneous, meaning like a blueberry muffin or a chocolate chip cookie, right? And so the cells are not always uniform in their growth rate and their expression of different hormone receptors and things within a tumor. And so when we do scans like PET scans, which look at the whole body, we call it from eyes down to the thighs, really, it helps us to see metabolic activity, glucose uptake, how fast are the cells metabolizing the glucose that we give it. And it tells us where there might be distant disease. Some of the newer imaging takes that a step further and helps us to see not only where the cookies are, but how much chocolate chips are in them. How many of these tumors are expressing estrogen, how much estrogen is there, so that, or how much estrogen receptor expression is a better way to say it, because we know that certain drugs will respond better to the higher degree of estrogen receptor positivity there is. So it's a really more sophisticated way of looking at the distant metastatic disease to see if certain drugs might be more favorable or have a better effect. How's that in its simplest form? Because I'm not sure who's all watching, but I'm trying to talk at a level that, you could kind of.
Can you maybe touch on when would be the right time for an ER positive patient to seek out molecular imaging? Are there limitations to some of the other imaging available during that initial testing?
I'm going to pass the mic on that one because I quite candidly typically don't order this testing because it is something that impacts the treatment in a different way, and so that usually may be my medical oncology colleagues. So I'm curious to know at what point they would order an FES PET over an FDG PET.
I can add a little bit here. So, I would say when Dr. Nolman was talking about this, I was just thinking, what do we tell our patients? It's so complicated to say, oh, this is the mutation and this is what this mutation implication is. And it's just too much overwhelming information. I think it's overwhelming for physicians too. There's so many different kinds of alterations, right? Some are actionable, some sound actionable, but they might not be. And some might be just newer mechanisms of resistance. And we're trying to understand them all. So I think we can't expect our patients to understand any of that. But a simple way of thinking about this for patients is there are certain mutations that we try and look for. One, because that can perhaps explain if there is a family history which is causing breast cancer. And that good example is a germline BRCA mutation. That's one. And if there are mutations that are making your individual tumor grow, they have no implications of what that would do to your children, to your siblings, or anybody else in the family. But that's probably helping us understand if there is a particular thing in your tumor that is particularly making your tumor grow. And do we now have either clinical trials or approved new therapies that can specifically try and slow that process down? So that's how I think about genomic alterations and genetic alterations. The genetic ones being the BRCA, which is something that we pass along. We want to see if I've been diagnosed, can my daughter get enrolled into this program for screening, and how can we try and look for it or prevent it? And that has implications of that kind, both for the patient itself, but also their family members. And the genomic ones that we're looking in the tumor and the blood, I should try and see what can we do to the individual tumor growth by understanding the biology inside it, and how can we act on it. So that was the one thing that I wanted to just add, just for patients to think about differences between germline or genetic mutations and genomic alterations. Now for imaging, that also is complicated, as we were talking about. It's so hard for patients to understand what is the right thing. Does this make sense for me? So we have traditional imaging, such as CT scans that we do. We have bone scans for patients with cancers in the bone. And then we have molecular imaging, such as PET scans. And usually when we're talking about PET scans, we're talking about FDG PET scans, so fluorodeoxyglucose PET scan. And as it is, sorry, I'm like answering the polling questions as I'm talking. So, and FDG PET scans, as the name suggests, is looking at the glucose metabolism. So think about how does an organ work versus what does the organ look like. So if you were to take a snapshot of your liver, what would you see and how well can you see the details is what an anatomic imaging like a CT or an MRI is. If you're thinking about FDG PET, you're thinking about how much is lighting up. So think about it, too bright is taking up too much glucose, and maybe there is something that we need to understand what that lesion means. If it's not picking up, it's not active. So there is nothing happening there physiologically in the body. So I think about the analogy. I love your analogy of blueberry and chocolate chip. And when I am thinking about it, I'm just thinking about I have a certain location to get to, and I have a sense that this location is somewhere in New Jersey, and this is where I'm trying to get to. If I have a GPS and I want to know the exact cross street, I'm looking for an anatomic scan, right? I'm trying to see where in the liver am I measuring something, I'm finding something, and I'm getting to. On a PET scan, I see something is lighting up in the liver. That's how I think about them. So one is giving more of a physiology in some ways because of the glucose uptake, how active or not it is, and how dark it shows up. And one is just telling you the measurement. So when patients are on clinical trials and we're trying to understand, does this therapy work? And sometimes we will do CAT scans for trials because that's what is more established, because you can actually measure something or follow it very closely with measurements. We're thinking about that. Now, to complicate this more for patients, we now have newer scans, right? We have additional tracers, additional molecular imaging, and that's for the good. We want to have more so we can get more information. And that is fluoroestradiol PET or FES PET or the Syriana PET as we call it. And that's a newer thing that has recently become available in the diagnostic categories for our patients. And it's applicable for ER positive patients. That's one. So sometimes I have patients, who hear about these new scans or new tests and they come and discuss about them. And so it's not necessarily for a triple negative breast cancer patient or a HER2 positive breast cancer patient, but this is more for an ER positive breast cancer patient. And it is approved as an adjunct to or as something in addition to biopsy. So is it that it should be applied for all patients? Should every patient get that? And that's the only way their disease can then be identified and treated? I don't think so. We have different patients can get different ways of their tumor tested, but this is an additional test that's available. And we think about utilizing this test when we're not able to get to an answer in some ways in my mind. So I have somebody with, say, invasive lobular cancer, and when I look at scans, their disease is just so very low active. So when we do an FDG PET for a patient with lobular cancers, they don't light up, if you will, because that tumor is not very high grade. That tumor is not very active. It's not something that's going to light up on an FDG PET. And sometimes we might not be able to identify disease, which is very frustrating for both patient and physician. We might see patients where tumor markers in the blood are rising, but we're not seeing a big change in scans, and it's hard to know what's happening. We have to go with symptoms, with blood work, and come up with a decision, not just based on one modality. So there, I think Syriana PET potentially could help, because if it is lighting up and if it is showing up better than our traditional ways of looking for it, maybe it'll help us understand, yes, this is where the disease is, and yes, this is why we need to do this. So that's one. Or say if somebody cannot get a biopsy, right? First of all, when we do a biopsy for a newly diagnosed metastatic patient, we're also assuming that the rest of the lesions are a reflection of that one biopsy site. That's how we've been treating this disease, because we cannot biopsy every site. It's hard, right? But if that biopsy also is difficult, either it's in a very tricky part of the lung, or it is something which is not accessible, can we do a non-invasive scan, such as a Syriana PET perhaps, that might light up in that area and help us say, go after this lesion because it's lighting up here, which was not seen before? Or biopsy cannot be done, but there is a lesion, and then maybe that will give us more of a comfort for offering them ER targeted therapies. So there are guidelines now that have now been published, and those guidelines will not only help understand the clinical scenarios, but also a very important piece is how much of this is being covered by insurances, which insurances will cover what kind of scenario when these tests are available. And so hopefully those criteria will help both the clinical situation where this could be considered and also guide the reimbursement and insurance piece that can get very tricky for our patients sometimes.
Absolutely. I think that overview that you gave was really, really helpful. Just outlining the different types of tests and the usage for those tests. And I know that you feel free to drop off when you need to, but we appreciate how much time you've been spending with us this evening. I also just wanted to bring in Kelly, who is a metastatic breast cancer patient and advocate. I know that she's not able to be on video just due to her connection, but just wanted to see if there was anything else that you wanted to add from a patient perspective.
Thanks, Jamil. There's a couple things. We were talking about genetic testing, and for years there's been this sort of, if you're early stage breast cancer diagnosed before age 50, you should have genetic testing, and metastatic at any age, and that's still not happening. And especially with the advent of PARP inhibitors for people who do have a BRCA mutation, I think it's incumbent upon oncologists and people in the oncology space to offer this to every single solitary person diagnosed with metastatic disease, male or female, because remember, men also get breast cancer and metastatic disease and are more likely to have a germline mutation. But it's still not happening. And, that's one of the things I know that Chrysalis is really working on, and a lot of other organizations are working on. So I think from the patient perspective, if you're diagnosed with metastatic breast cancer and your doctor does not offer you genetic testing, you need to ask for it. There was a question in the Q&A about ESR1 testing, and I think this is another area that's really ripe for additional usage, especially if someone had early stage breast cancer, were taking tamoxifen or an aromatase inhibitor, and then develop metastatic disease, either while they're still on therapy or shortly thereafter. There's a good chance that they have developed this ESR1 mutation. And aromatase inhibitors don't work if you have an ESR1 mutation. So I think if that's the case, that if your doctor doesn't talk to you about testing for ESR1, that's something that you should ask for. And again, I think, we put a lot of burden on us patients, and that's just not right. Oncologists, medical professionals in general are crunched for time, and that's problematic. I have some very strong opinions, which Jamil has heard, and some of you others may have heard, about things like navigation. I strongly believe there should be a national system funded by the government and academia, and sure as heck by industry, that provides navigation to patients newly diagnosed with advanced and metastatic cancers, to let people know about clinical trials. I may be a physician, but when I was first diagnosed with metastatic disease, I saw a community oncologist who actively discouraged me from seeking a clinical trial. Because if I had a clinical trial, he wouldn't have made money from treating me. And there are people like that in the world. You guys are all academic physicians. 80% of us are treated in the community. It may be slightly lower with people with advanced and metastatic cancer. So I think those two things about genetic testing for everybody with metastatic disease, and looking at some of these biomarkers that we have, there will possibly be an FDA-approved treatment for people with ESR1 mutations in the next year or two. I'm talking about lasofoxifene and the ELAINE trials. And then looking at imaging, and somebody was mentioning lobular. Lobular, forms little sheets of cells. It doesn't form clumps or balls. So it's more difficult to see on that traditional glucose-based PET, and frankly, on most other imaging modalities. So we need research into what may be better. I participated in a trial. It was a single center trial of a novel tracer called FAP, fibroblast activation protein. And because it's not just the cancer cells, it's the stuff around the cancer cells that may also help us identify. And this is looking promising. It might be promising for lobular. It was looking super promising for other cancer types like bladder cancer, but also things like I'm ER positive, HER2 negative. I have extensive bone mets. I literally have mets from the top of my head to at least my kneecap. But we've never seen my skull mets on any PET scan, because when the brain lights up, because our brains use so much glucose, they light up. But the FAP showed all of my skull mets in great detail. There are trials going on using sodium fluoride as a marker in PET scans. It's being used in prostate cancer for people with prostate cancer and bone mets. And I'm working with a researcher who's trying to get funding to do this in metastatic breast cancer because it also can show bone mets better. One of the big problems for those of us with bone-only disease is it's hard to measure bone mets. And so therefore we don't qualify for a lot of clinical trials. So there's a lot of room for improvement. We need research, excuse me, and we need research that involves every demographic of people involved, old people, young people, Black people, white people, because the drugs are different. So we need to look at all that. We need research for all of those things.
Right. And I just want to also touch on that the Chrysalis Initiative, we are assisting folks to advocate for themselves in order to make sure that they can get, these type of tests covered. And there's so much support out there now as far as, just grants that are available. So don't think if you get that initial decline or refusal from the insurance company that you can't continue to advocate to make sure that you're getting this testing done, including the FES PETs, because, as more research happens, as more advocacy organizations are doing the research, putting forth, having evidence-based, it really then presses the insurance companies to approve that coverage because of the appropriate use criteria. So I just want patients to not feel discouraged because all of this information is vital in order to make sure that the most personalized, precise treatment plan is outlined for each individual. So even things that are in being studied in clinical trials right now, there's nothing wrong with asking. You won't know unless you move forward. I know personally, I have asked for ESR1 mutation monitoring with additional ongoing genomic testing. And, it is definitely applicable in my care. Living with MBC. And so I think there's so many tests that are available to us now, and we should not feel discouraged to ask for them. So I think we've really gone did a deep dive into the initial diagnostic workup of testing, but I also wanted us to talk about maintenance and monitoring. And so we find that many patients with MBC or advanced breast cancer are confused about how much maintenance and monitoring should they be receiving and what tests are involved with making sure that their treatment is working. Dr. Noman, can you touch on what an MBC patient, I know understanding different subtypes and different disease states and areas as far as characteristics, but what is the standard of care just for maintenance and monitoring for patients with MBC?
This can also really vary from person to person. So, standard of care from a maintenance and monitoring standpoint are things like blood work, office visits, and then intermittent imaging. And again, this really varies depending on the situation. For example, if someone is on an IV chemotherapy, they're going to be coming pretty frequently for blood checks and provider visits. If someone's on an oral regimen, there are algorithms that we follow, of how often the person needs to be having their blood checked. In terms of the imaging, this can really vary. If someone, has had a recently progressive disease, say, and is having a lot of symptoms related to their cancer, I might be more inclined to do a scan sooner than later. If someone has been stable on a regimen and they're doing well, feeling well, I typically tend to push scans out. So I really use clinical judgment here to determine how often someone is getting imaging and visits. But this, really dictated by how the person is doing, how their cancer has been behaving. And ultimately, this informed discussion between patient and doctor. I'm always talking with patients, talking about standard of cares, but also, trying to let people live their lives and see how I can help them feel their best possible, live their best lives possible, and help keep them here as long as possible. And, you'd be surprised the difference in what people's desires are as well. Some people have a lot of anxiety with imaging. And if that's the case, I try to, be a little more cautious with that. And if, that's just one example of why from one person to a person, there might be a difference in their surveillance imaging. Our national guidelines do give a lot of leeway here. So you might see variation from provider to provider and center to center on this type of thing. I think that's what I wanted to say. I don't know if anyone else has any other.
I think it really speaks to the, sorry to cut you off there. My Wi-Fi cut up a little bit. The ongoing conversation between the medical oncologist and that patient. How are you doing? How are you feeling? What symptoms are you having? Looking at the constellation of things like blood work to determine if further imaging is warranted. There's I think a constellation of things that can dictate how often imaging should be done, but it should be a shared decision making, because what I find is that when patients don't understand when it's going to be or why it's going to be when it's going to be, it's a real gray area. And it can feel like disregard sometimes, even just talking to patients, like, when am I going to be imaging? I'm on this drug, but how do we know it's working? And I think those are really valid questions to ask. And that's why I said it really should be a shared decision-making model, and it should be pretty clearly mapped out for that patient, why we're selecting what we're selecting as far as when the imaging and monitoring is going.
Can we also touch on just not just the monitoring as far as how the cancer is behaving, but as far as the toxicities or comorbidities that could develop? How do patients know, without the recommendation of their oncologist or primary doctor, what other monitoring needs to take place, such as, just a cardiologist, or, bringing in a gynecologist, or, being mindful of any comorbidities that could develop? Can either of you touch on that additional monitoring that should be done just with the management of MBC?
Yeah. So as a medical oncologist of someone who takes care of only women with breast cancer, I often become a pseudo primary care in some cases, because patients will see me so often and will sort of lose touch with their primary. I certainly encourage patients to maintain a good relationship with a primary, or establish care with a primary if they don't already have one. I hear a lot of times people say, well, why do I need a primary when I have you? And, it's primary care docs, think about other types of health screenings and things that, that may not be on the forefront of my mind coming from a breast cancer treatment standpoint. But, at a place like Penn, we have the great benefit of really wonderful colleagues in so many different fields. So we work with a specialized team of cardio-oncologists, gynecologists, pulmonologists, and I so often involve these colleagues of mine into patient care. For example, just this week, I emailed a rheumatologist and asked for a recommendation. I explained the situation with a patient. I said, do you have anyone in mind that would be a good fit for this patient of mine who has this particular rheumatologic problem? So I think that's a great benefit of being at a big institution where we have, whether it's a community practice or an academic center, but having a medical oncologist who can work well with these other providers. Because that's really, really important, because sometimes medical comorbidities like high blood pressure or COPD or diabetes may certainly impact someone's care. I've certainly had times where someone's other medical problems have impacted or inhibited their ability to tolerate their treatment for breast cancer in one way or another, or has impacted their clinical trial eligibility. So it's really quite important to encourage patients to maintain a relationship with their primaries and their other, providers for their other medical problems. And I find too often that people do kind of fall out of care. So I really try to be on top of that. I also, just from doctor to doctor, I really do try my very best to send my notes to primaries. It's a routine part of my day when I'm closing notes after seeing a patient. I always send a communication to that person's primary care. It's a click of a button in our computer system. And I don't know if they read it, but I find that really important because that really is the link between me and the primary. And I reach out to other doctors a lot on patients' behalf. Hey, here's what's going on. What do you think? And that's my style. But so I think if you have a doctor that you really think you'd benefit from having your oncologist talk to your rheumatologist or whatever it might be, you can always ask. And again, this is along the lines, a very common theme tonight, but of this shared medical decision making, because these types of things are very personalized, to each patient.
Absolutely.
I think it's up to us to connect patients to these resources. So if a primary care is managing diabetes, and I know a patient is getting steroids and their blood sugars are out of control, it's up to me to say, hey, listen, let me connect you and talk to your primary as well, but connect you to the endocrinologist, or patients who are who have rheumatologic disorders, who are undergoing therapy and they're, may not be partnered with a rheumatologist, et cetera. I could refer, or I can say, let me make these connections for you and with you, and let's get the navigator in here and let's really help this patient get where they need to go. And on the part of the surveillance, part of my job is checking in with that patient and saying, okay, how are we doing with these side effects, with these symptoms? When's the last time you had an echo? And when's your last DEXA scan? And, make sure that the patient as well is sort of prompted to know what to expect, from their treatment, or that they might expect some cardiotoxicity. And what does that even mean? Are you short of breath? Can you make it up the stairs? How many pillows are you laying on at night? And there's some basic kind of conversations that I can have, while I'm doing a breast exam and checking in with the patient, that sort of helps them to understand as well what they should be looking out for at home. So I think it really is a team approach there, but not letting a patient fall through the cracks by just referring to specialists, is something that we need to do more of, even when the systems aren't as integrated. And thankfully, we're a clinical partner with Penn, and we're able to utilize those resources. But where they're outside of the system, some navigator should be helping to make a call and connect those patients.
I'm cracking up at this because I live in a community where, number one, there's no oncologist in my town. We have no endocrinologist, no rheumatologist. So this, I'm just, but if you need orthopedic surgery, you're good. I kind of want to go back to the whole monitoring and testing thing. And one of the questions in the Q&A was about circulating tumor cells. And I think it was around colorectal cancer in the last couple of weeks where something came out about the utility of monitoring circulating tumor cells to look at treatment efficacy. When circulating tumor cells decrease, it's suggestive that current treatment is working. I'm an advocate on a grant where we're going to look at that for metastatic breast cancer. And I think that, right now it's not something that's done standard of care. I know Massimo Cristofanelli is really interested in CTCs and has published some work on that. But I think we need more of these type of biomarkers. And also for those of us with mutations, I personally have both ESR1 and a PIK3CA mutation, as well as a weird KRAS mutation. That looking when you start a new treatment, if you have this next generation sequencing, you have 12% of an ESR1 mutation, and you start on a therapy, looking at the decrease in the fraction of these mutations may also be beneficial. It's not there yet, but I think there's work going in that space. And hopefully this information about CTCs which has been useful in some other cancer types, might also be useful in MBC. And I wanted to address that Carolyn asked in the Q&A.
Thank you. So to close out the testing that we're talking about with MBC, I know that there's also a lot of confusion when progression happens, when that bad scan, occurs. As in order to identify what should be next as far as what the next treatment is to get that cancer back to under control, stabilized, eliminated, what that we can shoot for. Can you touch on just if that bad scan occurs, what is the appropriate testing for patients to receive with NBC if they do have progression?
Again, really personalized question. And again, really, it's a shared decision-making with your oncologist. When someone progresses, I'm thinking about things like, is this symptomatic? Is this a significant progression that warrants a change of treatment? What treatments has this person had before? How long has this person been on this treatment? Have we had recent genomic testing? So do I know what's driving this tumor? Was this progression expected or unexpected based on the history, and what are the comorbid conditions? What are we up against here? And overall, what are the patient's goals? So much of this is what does in meeting with patients, talking with patients every day, it's always that, tell me what your hopes are. What are your fears? It's always trying to assess, how do we come together to make the most reasonable next decision? I will often think of what's standard of care and think about things like, those comorbid conditions. What side effects has a person been experiencing? What side effects do we want to avoid moving forward? Quality of life, thinking about all of these things. So there's certainly not one answer to that question, but it really is, I have to say, when I'm seeing patients, following patients over months and years, I'm often thinking about in my head, what is the next treatment? Is there a trial that, I might have in mind for a patient, or what is the next line of treatment? And is there anything I need to do to get things ready for when that time comes? So, I always try to be a step ahead and think through that, but ultimately there's so many questions, or so many factors that play into the decision of what do we do next? Absolutely.
And so when that progression occurs, are you confirming the subtype is the same? Is there anything different that's going on? Are we doing updated genomic testing if possible, if there is, viable tissue to actually do that type of testing? And is there a place where if it is difficult to biopsy, how do you utilize the additional testing such as FES PET in order to determine whether or not if this new progression is ER positive driven?
So really depends a lot on the situation. So if someone has, someone has tumor in the liver and the lung, and that has already been biopsied each site, once at progression the last time, and the liver the time before that. So if someone's already had multiple biopsies, I'm not necessarily thinking about putting them through another biopsy if the prior biopsies have been consistent. Instead, I might think about reaching for what we call a liquid biopsy, which is that circulating tumor DNA testing. This is a blood test rather than a needle biopsy that gives us information about the genomic mutations or the driver mutations in a cancer. And sometimes if someone's already recently had genomic testing and or a needle biopsy, I may not need to even think about those things at all, but just move on to the next treatment. So again, that's very much an individualized decision or discussion with the patient. And there are so many factors weigh in, to that decision. But these days we really have a lot at our disposal. And this new FES PET scan, we've had this here at Penn on study for a couple of years, and it's really exciting that it's now available outside of a clinical trial. I had actually ordered this for a patient 2 or 3 weeks ago, a woman who it was felt quite unsafe to proceed with a biopsy for reasons which I won't go into, of course. But the scan in her, it was really a diagnostic dilemma of what type of cancer she had. And the FES scan was very, very informative in her case. And it really saved her of having to go through a needle biopsy when that biopsy was felt to be really high risk. So I look at this FES scan as just one additional way that we have to help monitor patients, help diagnose and treat patients. And I don't think that there's any right or wrong answer, in thinking about how to work a patient up, but you have to kind of think about what testing they've had before, what has happened up to this point, and what are we moving towards, and what are my clinical suspicions. Hard to talk here in sort of generalities, but ultimately, in my 5.5 years here at Penn, I've seen a lot of changes, both in terms of medications that have become approved that were once on trial, some of them here at Penn, and also things like the FES PET scan, which is now FDA approved. This is really cool. These are tools in our tool belt, that we can use to help move care forward.
Absolutely. And Kelly, did you want to add it?
Oh, sorry,
I just wanted to add that, one of the things is especially if there's a mixed response where some of your mets are responding to your therapy, but others aren't, then I think that's super important to get, if possible, a tissue biopsy. I'm a huge fan of liquid biopsies. Obviously, who wouldn't rather have blood drawn than having a needle stuck in your body? But one of the problems with liquid biopsies is you can't assess for receptors. You can't assess for estrogen receptor and HER2 with the liquid biopsy, although there is, again, some work going in that area. But I think if there's a mixed response, that it's incumbent upon, I've heard so many other patients, like, I'm having progression in some areas, responding in some areas aren't. And my doc's just, let's just keep going. And I'm like, did they talk to you about a biopsy? Because often there can be a change. You could be estrogen receptor positive, and now you have some of your mets are becoming triple negative. This, again, I think is a great place for something like Siriana, because if someone has been estrogen receptor positive and is starting to not respond to therapy or has a mixed response, you can do this to see whether this, area that previously was ER positive has now changed. But again, not all oncologists. And again, I'm out in the road. I'm very blessed in that I have a wonderful, wonderful community oncologist who's only an hour and 15 minutes each way away. And I also am lucky enough to see one of the world's most renowned metastatic breast cancer experts in San Francisco. So I have the best of both worlds, where I can either travel an hour and a half each way or 4 hours each way to get good care. But, you have to think of things like that too, that, as someone mentioned earlier, our cancers aren't heterogeneous, and they don't stay the same our entire lives.
Right. Dr. Mo, you have something to add?
Yeah, the only thing I had to add was for the people who may be watching, who are advocates, who are NBC thrivers, the only wrong answer here is that there's no conversation, and that there's no change, and that there's no discussion at all, because we hear those stories too. I just continued on the same drug, even though the scan came back and it was, it showed progression of disease, and no one called, no one talked to me. I read it in my portal, and I guess I'll just keep going on this. And then what? And then we refer to Jamil, and then we refer to Chrysalis, and then we have to have a conversation about how to have that dialogue with your medical oncologist. And so I think the only wrong answer is when there is no shared decision making. But, again, on the lips of every patient should be why. If we're going to continue this, why? If we're changing this, why? What informs that decision? Because, you know, that answer gets to the heart of what that medical oncologist is thinking. What is the evidence? What are the guidelines? What's new and innovative? What are the possibilities, and what comes next? And so it's probably one of the most important questions that we can learn to ask. But I just want everyone to know that, you know, advocating for yourself looks like there should be some stopping point at the point of abnormal scans. There should be a conversation about what are we looking for? What are we thinking is happening? What are we going to do next? And from there, any plethora of things, as we mentioned, could happen. But, you know, that medical oncologist must be the advocate. That patient really must be the advocate. And it's just as simple as those 3 letters.
Yes, absolutely. And I just want to say, those patients who do feel overwhelmed, we're really proud of the work that we do at the Chrysalis Initiative. You are not in this alone. We work with so many partners and other organizations as well. And oh my goodness, I think we're out of time. But I just want to thank Dr. Gary and Dr. Noman and Kelly and Dr. Javeri for this jam-packed informational panel. And also thank you for everyone that joined our breast cancer education series launch this evening. And thank you for staying the entire time and being patient during our technical difficulties in the beginning. But I also want to just give a great appreciative shout out to our sponsor, GE Healthcare, who I would say is a tremendous you know, sponsor for equity. And, you know, it really is easy to, you know, say that you're committed to equity and just only focus on those status quo solutions or those status quo organizations, but really taking the time to invest and support organizations that are pushing the envelope and being innovative. I really have to take my hat off to them. And so I think, is Anthony going to close this out?
Yes, indeed.
Thank you so much for everyone.
When I wake up in the morning, love, and the sunlight hurts my eyes, see something without warning, love, weighs heavy on my mind. Then I look at you, and the world's alright with me. Oh, I just wanna look at you, and I know it's gonna be a lovely day. Yeah, a lovely day. Yeah. When the day that lies ahead of me seems impossible to face, yes. When someone else instead of me always seems to know the way. Oh, then I look at you, and the world's alright with me. Oh, I just wanna look at you, yeah. And I know it's gonna be a lovely day. A lovely day. Oh yeah. It's gonna be a lovely day, 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 lovely lady. Thank you.
Woohoo.
It's really beautiful. Thank you.
Thank you so
Appreciate you.
much. Thank you again,
Good
everyone.
evening.
Thank you.
Connect with us and follow on social media, the chrysalisinitiative.org, and connect to us for support at bcnavi.com.
Okay.